Next session, with great pleasure, I would like to invite Dr. Parshuram, Professor in the Department of Medicine at Dr. B.R. Ambedkar Medical College and Hospital, Bengaluru. Pleasure to have you, sir.
Good afternoon to everybody. Myself, Dr. Parishuram. Today we have a talk on diabetic food. I'll call upon Dr. Ajith Kumar Shivshankaran sir. He is MD, MRCP and FRCP, and he is a Chief Consultant, Department of Hyperbaric Medicines and Diabetic Food, Hospital in Trivandrum. Sir is working as a professor in internal medicine, and he is a governing council member of RSDI, Kerala chapter. And sir has got a lot of publications, national and international. Sir, over to you, sir.
Thank you, Chairperson. Very good afternoon. You know, it's a postprandial session. I think most of you may be feeling a little hyperglycemic. First of all, I would like to thank LSM sir and the team, Islet Academy, for this opportunity. So my talk will be a little different from what you was hearing in the last few hours. So this, you may have read about this hyperbaric oxygen therapy in diabetic food in textbooks. So I'll try to, next 20 minutes, I'll try to share our experience and our data. This is my disclaimer slide. This is the first center that we started at Trivandrum about 20 years back. So I'll be briefly mentioning about the magnitude of the diabetic foot infections, the importance of limb saving concept, the role of HBOT in problem wounds, our experience, and the available worldwide evidences. So chronic non-healing ulcers are a major cause for morbidity and mortality, as we all aware. It leads to amputation and limb loss. It may be a very difficult scenario for a patient to overcome an amputation. And there is an intense need to explore a non-invasive limb-saving approach, and there is a new window of hope has emerged a few years back that is in the form of hyperbaric oxygen therapy. This is a famous article which had come about 20 years back in Lancet, that is every 30 seconds a lower limb is lost somewhere. But the recent data says that every 20 seconds a limb is lost somewhere in the world as a consequence of diabetes. So we know it is a very high problem that we have to accept. And burden, about 15 to 25% of diabetes patients will develop diabetic foot in their life, in the foot during their disease period. 20% of diabetes mellitus patient, the IP reason is because of diabetic foot infection, maybe a mild cellulitis to osteomyelitis. Lifetime risk of foot ulcer in diabetes is 15%, and we know that 85% of lower extremity amputations are due to diabetes, which starts with a small trivial foot infection. Most of the time patient and the physicians may ignore. If anyone of the crowd who is sitting and thinking that this is the best way to treat diabetic foot successfully, then I'll be really say sorry that amputation may be easy for the treating doctor, but it may be difficult for the patient. The literature says foot, as far as possible, foot has to be saved in diabetes because BK amputation requires about a 40% more calorie consumption, and 5-year mortality after amputation is 70% in diabetes. That is why all over the world there are a lot of research which is going in the field of diabetic foot ulcers, how we can save, at least if we can limit an amputation to a minor amputation from a major amputation by any available method, whether it is a peripheral angioplasty, whether it is VAC therapy, whether it is HPOT, or whether it is stem cell therapy, it is good for the patient. We all know how much efficient is our healthcare setup. We have, in every nook and corner, we have acute coronary care units, we have stroke units, we have renal replacement units. But think about dedicated diabetic foot care units in either in your town or your nearby towns. I think it may be, answer may be nil or it may be 1 or 2. There's a few interesting cases. I'll start with this as one patient who has a critical limb ischemia. He had been amputated, metatarsal amputation reported to us. The surgeon advised for a BK amputation. You can see the amputated, the ischemic stump is there. You can see from this side. And we started him on HPOT. He was having high HbA1c. Finally, this was a picture. This completely healed, and he was doing well for last 5 years. There was no recurrence. It's again very complicated situation, peripheral arterial disease, old CAD patient, gangrene of fourth toe. Angioplasty was not possible. We may think about angioplasty, but it is very difficult because infrapopliteal disease is diffuse in a case of diabetes patient. But most of the time, the cardiologist or the interventional radiologist will find it very difficult to pass the stent because of the narrow vessels. So 80 sessions, you can see we have to do a little bit of debridement of the tip of the toe, partial amputation, but the patient is doing very well. Was again an interesting patient with an obstructive sleep apnea, about 120 kg weight, heel pad region gangrene, and he has been given GLP-1, that is dulaglutide, a few years back, and little bit of weight loss he had, and you can see the gangrene. This is a very, very difficult portion to treat, and you can see the good granulation. We put a small graft and he completely survived. This was again an underlying vasculitis in a diabetic patient, non-healing mode. Young lady, you can see the dirty wound. It was full of multiple drug-resistant organisms. Finally, we got a healthy granulation. We put a small graft. She is also doing well. This is again a complete obstruction of below popliteal artery. 30 sessions, this lady has completely recovered. This was one problem. Most of the surgeons or the physicians who are looking after the diabetic foot will face the coexistence of osteomyelitis. You can see one artery forceps, half of the artery forceps will go inside the foot cavity. Finally, completely healed, and he is using modified footwear and doing well. This is a KSRTC conductor, so he was underwent a surgery following an accident. So there was an osteomyelitis, chronic osteomyelitis of femur, and he also completely recovered, and you can see the beautiful healed, healthy scar. So normal wound healing, why it got delayed in diabetic foot? You can see the angiogenesis, the migration, the polymorphic reaction is affected. It will be delayed because of the inflammatory process which happens in diabetes. That is why the wound becomes chronic in a case of diabetes. The history of diabetes HPOT starts from way back about 300 years back. So when the Henshaw used the compressed air, but the discovery of oxygen in 1775 actually revolutionized the use of air in modern medicine treatment, and the first international conference started in 63, and India procured the first chamber in 1966 in Indian Navy, that is in INS Ashwini, Mumbai, and later a lot of changes has been happened. But what is HPOT means? It involves an intermittent inhalation of 100% oxygen in a pressurized chamber which is above 1 atmosphere absolute, because I am coming from Trivandrum, there the sea level pressure, but when you come to Bangalore, it will be a little high. That means it is 3,000 feet height it comes. So there may be difference, but the simple physics, it says HPOT causes hyperoxygenation by increasing the dissolved fraction of oxygen in plasma. That is what important, because all the biochemistry textbook says the dissolved amount of oxygen, fraction of oxygen in the plasma is the principal determining factor for the cellular function to happen. So 1 atmosphere absolute, it is 760 millimeters. We all know the 97% is bound to hemoglobin, but wherever you increase the pressure, the oxygen absorption will be increased in the, that is based on the physics law of, we go back to the 10th or the 11th standard, the Henry's law. So solubility of gas is directly proportional to the pressure. That principle is applied here. So the oxygen dissolved in plasma is at sea level pressure is 0.32%, but when you give it to the 2.5 atmospheric absolute, that is a universally accepted pressure schedule for the treating of non-healing wounds. It becomes 5.62. You can see from 21% oxygen from 180, when you go to 288, 100% oxygen, your plasma is full of oxygen molecule. So this is a wound healing process, because lack of time I'm just going through. These are the 3 phases of wound healing: inflammatory, proliferative and maturation. But there are 5 important cellular events to happen if this process has to be complete. That is angiogenesis, the mitogenesis, the chemotaxis and motility, and the fibrogenesis, and the remodeling of the basal membrane cells. So how we'll say how it affects the wound healing. So if any of these problems get affected, then there will be a stalling of wound, or the wound will not heal properly. Especially nowadays, there is a burden called biofilm is also coming up. So problem wounds means whether it is a diabetic foot, whether it is a compromised amputation site, non-healing traumatic wounds, venous ulcers, vasculitis, radiation, or anything refractory osteomyelitis, all these things share a common problem, that is tissue hypoxia. So in any available method, if you can overcome the tissue hypoxia, your patient will be able to save his limb. So basically there will be hyperoxygenation of tissue which will happen, that will facilitate the angiogenesis. There will be increased collagen synthesis. There will be production of growth factors which will favor the cellular membrane to start growing and inhibits the bacterial growth. This is the basic principle of HPOT. By improving the oxygen transport at the microvascular level, and the higher oxygen tension overcomes the hypoxia and the ischemia by the centrifugal diffusion. And from the normoxia, the red blood cells will be replaced by the hyperoxia. And there will be reduction in edema because there will be a little bit of cardiac output changes occurs, and this will reduce the blood flow, but it will not compromise the heart function. The reduction in edema facilitates lymphatic drainage and less stasis of venous blood. So that is why it is much important in crush injuries and compartment syndrome. Compartment syndrome, it is one of the life-saving method to, or maybe life-saving for the limb of a patient. You do a fasciotomy and put him on inside the chamber. I think patient will be okay within 2 weeks' time in case of a big compartment syndromes. HBO has got an bactericidal and bacteriostatic action because you all know the PMN function will be sluggish in hypoxic environment. So once you can overcome the hypoxic environment, the PMN function will facilitate. And angiogenesis and epithelialization will be promoted by these cellular things, but because the wound healing, the reconstitution of basement membrane is consists of type 4 collagen and laminin, and hyperoxia enhances the endothelial response to angiogenic factors. One thing you have to be very careful, these angiogenic factors will not promote a tumorogenesis. That is the principal thing. So there is no risk for any malignancy. And HPO enhances the fibroblast because this is very important. The terminal step of collagen synthesis, that is a conversion of hydroxylation of proline and lysine, which is directly dependent upon the oxygen tension. So wherever you can overcome or you can reach a PO2 value at the cellular level of more than 30 millimeters of mercury, your cellular function will happen without any hassle. And it has got an antibiotic synergy because these are the reserved antibiotics. We usually use it for resistant infection, that is aminoglycosides or amphotericin or fluoroquinolones. All these antibiotics are oxygen dependent for their transport across the cellular membrane. So if the oxygen saturation is improved, the antibiotics bioavailability will be increased, and there will be more response for the infections. To summarize, these are the mechanism of action that we had discussed. Epithelialization, bond healing, angiogenesis, cell replication has to pay little bit attention. So this is a way it has been given. It is monoplace and there is a multiplace chamber is there. This is what we use. It is a simple mask by which through one side oxygen comes and through the other side the exhaled air goes outside the chamber. These are the indications approved by the higher authority. India follows the UHMS guideline. There are a lot of European society, German society, everything is there. Now I think in sooner or later the Indian guidelines are coming up. It's under the process by the Ministry of Health. So these are the approved indications: the air, gas embolism, carbon monoxide poisoning, healing of selected problem wounds, necrotizing soft infection. A lot of things are there: refractory osteomyelitis, decompression sickness, gangrene. And nowadays sports rehabilitation is gaining much importance in this. Recently, I think you may have read it in papers also, the Rishabh Pant also was recovering from his injury. He has also underwent HPOT to improve his fitness. Selection of patient, ECG, PFT is a must. You should not submit any chronic obstructive pulmonary disease or any bronchial asthma patient if they have a COPD changes, or maybe there is an underlying bullae is there, because there is high chance that bullae may rupture during increased pressure, can result in a pneumothorax. So two absolute contraindication is COPD, and second one is a seizure disease. And TCPO2 measurement, we do the pre and post. That will give you a more idea about, objective idea about the saturation of oxygen at the tissue level. This is the internationally recommended schedule. We follow one session is 90 minutes frequency, 5 days a week to avoid any concurrent oxygen toxicity. This chamber we use, it is 3 to 4 patients at a time. We have a communication system is there. This is a model. We use it in our center. Contraindication, as I said, absolute is untreated tension pneumothorax, and you should not submit any active URI patient because they will have a ear pain during the treatment and seizure disorder and claustrophobia. Side effects, very, very minimum. Only problem is they may have a little bit of pain during the ear, like what happens when we travel in an flight, when we land or when we take off. There may be, due to pressure change, there may be some discomfort in the ear. My role is to make all of you aware about this modality is there. It can be effectively used for non-healing wounds. This is our data. I'll quickly go because I have 7 minutes, but this is a chamber that we started in 2014, and the first 2 phases of study, because this data is 3 months old. So we had already treated more than 5,500 patients of different etiologies. Luckily, there was no unwanted event till date, except few correctable hypoglycemia inside the chambers, and average success rate was 69.7. So we classified the wounds according to this criteria: fully granulating, partially healed and the dropout. Those who had not completed 10 sessions of treatment, we put him under the dropout category. So you can see from the first phase or the second phase, the number of patients is somewhere around 210. Age was again 55 average. History of amputation was or disarticulation was 20 average, 20%. Duration of diabetes, you can see duration of diabetes is about more than 10 in about 45% of patients. So with increasing the duration of diabetes, more chance that wound will not respond to our traditional modality of treatment. And surprisingly, the POD was very high in our group. And these are the other etiologies, because diabetic ulcers was leading the table, because maybe because of a lot of what you call smoking in our part of the state. I think the incidence of POD is very high. We classified according to Wagner stage 3, 4 and 5. And pre-TCPO2 was 30, 35, and you can see it goes up to 55, or here it is 58 to 66. So, average increase of 15 to 20 millimeters of mercury has been resulted in this result. The first session it was 70.72, then it is 69.2, and average number of sessions was somewhere around 23. That depends upon the grade of the wound and the duration of the ulcers and the age of the patient. No improvement was seen in 9 in the first phase and 8 cases. Most of the thing was either Charcot arthropathy with osteomyelitis or an established peripheral arterial disease where there is no scope. The average number of sessions, the average increase was, as I said, 20 to 23 TCPO2. And recurrence of ulcer was been seen in 7.1%, and I think 3.5% underwent post-HPOT amputation. That was all amputation was minor amputations. This is one study we published, that is clinical utility of HPOT in diabetic foot osteomyelitis. Again, this was about 130 patients had participated, followed up for minimum. Again, you can see the duration of diabetes is 40, 50%, about 10 to 15. Other lot of comorbidities here. Again, POD is a strong association, and you can see the last is not the most ignored thing, that is the association of chronic kidney disease, which makes healing of the wound very difficult. These are the laboratory parameters. I'm not going into the details. And we got about completely healed in about 64% of patients. 39 patients out of this had a recurrence of ulcer, but none of them had not underwent any post-HPOT amputation. That was a big achievement, we think. This was we got the state-of-the-art diabetic foot clinic in 2017 for this work by the D-Foot International, what we have done. And this was the center. This was one interesting case we had treated, that is type 2 decompression sickness. A scuba diver, a Fire Force man has brought in a complaint, that means a comatose state, but we are able to save the patient. This was a little bit of international acceptance for our. This was one study which a case report we published, because it was hemorrhagic cystitis. A lot of patients nowadays are coming to us because with the refractory Crohn's disease and what you call the hemorrhagic cystitis following either cyclophosphamide or maybe following the radiation injury. A lot of indication, new patients are coming up. Very difficult condition, but the patients are getting good results. These are again our few publications. That's about one is about the clinical and bacteriological profile of non-healing wounds, South Indian experience. This was again the study which I had shown that diabetic foot osteomyelitis and role of HPOT as an adjunct. You have to think that this is an adjunct modality of treatment. You have to go for a stringent control of blood sugar, proper nutrition control, along with what you call the local available antibiogram or the international guidelines to choose the antibiotics. But this, you can use it as an effective adjuvant. The latest recommendation by the International Working Group is you can consider the use of systemic HPOT as an adjunctive treatment in non-healing ischemic diabetic foot ulcers. These are certain articles which is there available, because a lot of things are there. Current evidence shows that some evidence effectiveness of HPOT, but there are a lot of new articles are coming up, and in another 5 years, I think a lot of new publications, a lot of RCTs will come in this scenario. This is again effectiveness of HPOT for chronic wounds. This is about 22 years back study. This is again a double-blind RCT which has compared the use of HPOT to standard wound care. But all these studies had concluded that it is effectively can be used, and the patient selection is very important. And this is one study which explored the clinical evidence of HPOT in non-healing wounds. The dilemma in decision making, these are the two cases. See, established POD, post-amputation, these sort of patients, you can see it is really an ischemic wound. There is no peripheral pulse. There is TCPOT is less than 20 or 30. In that group, you should not submit the individual for HPOT. You are not going to get result. The same thing is like this. Charcot foot with the osteomyelitis at multiple sites. See, this patient also, there is no use if you give or if you don't give, patient will end up in amputation sooner or later. So current research and trends are this: post-traumatic brain injuries, rehabilitation of sports injuries. In another 1 decade, this will be one of the most common area where the HBOT will be used. So this is an oxygen revolution which is happening. Anybody interested, academics, lot of things are available in the things. But most important thing is you have the quality and the quantity in hyperbaric medicine. You should have adequate. I trained this from the Air Force Institute, which is situated in Bangalore. So proper timing of HBOT is very important. You should not use your best weapon as the last weapon when you are facing a battle. If you do that, you will lose the battle. So take a message, the HBOT shown significant improvement in healing of non-healing wounds. Early initiation is a viable option as a limb amputation, providing an amputation-free life for the patient. Limb-saving option like HBOT is promising as an adjunct treatment, potential to lower the total cost of medical care. If you ask me what is the cost of the treatment, it is 2,500 rupees, including dressing for a single session, and should be combined with proper diabetes, nutritional and wound management. That is the most important aspect. Always remember the pathway to amputation is littered with the bandages and dressings which have deceived both the doctor and patient into thinking that by dressing an ulcer, they were curing it by the great Sir Paul Brand. Thank you. Once you want, you should not happen this to the patient. We can give hope for your patients. We are there in Trivandrum. So thank you once again. I would like to thank LSM sir and the team ILET for this opportunity. Thank you all. Have a great evening. Jai Hind. Any questions, I'll be happy to answer.
Diabetic port, the one of the what we are experiencing now, it is almost what we can say is a system failure of because it is the late coming by the patient itself, and as a doctors, as a physician or diabetologist, we are not able to control the proper sugar controls. Again, we refer back to surgeons. Surgeons will send to the junior doctor. By seeing the smell only, you will run away. And all these things which are leading to the non-traumatic amputations of the leg, that is a very worst spot in the system. Thank you for giving elaborating things. I think, is there any comparative study with a good antibiotic, the regular dressings with HBOT?
I think a few studies are there, sir, but it says the antibiotics has got definitely a role in healing of wound, but only problem is majority of the time, if it is a chronic ulcer, what we have seen is the wound is not responding to majority of antibiotics. Most of the time, if it is Klebsiella level Proteus or even Pseudomonas, it will be multi-drug resistance, and the aminoglycosides will be responsible, sensitive. But problem is the renal function may be significantly affected, so we won't be in a position to give an amikacin or a gentamicin. In that kind of cases, I think combined use of at least some, especially what I use is a clindamycin. It is a very good antibiotics, good gram-positive, good anaerobic coverage, along with HBOT, and comparison studies are available. Often I am not sure, but I have read a few papers.
Any questions from audience?
Once you get a diabetic wound,
yes,
which is the best antibiotic to start?
Start.
Before you get your culture sensitivity.
Yes.
So actually, Dr. Arvind and the team had done what for 300 cases, just one, and they sent the after culture sensitivity, they had a protocol for this area where diabetic wounds are coming in Karnataka. They have a protocol to start. Which one, sir? Which are the two antibiotics you start for?
Amoxicillin, clavulanic,
amoxicillin, clavulanic acid, and ciprofloxacin. They found that was the first ones to start. Then, based on the once the culture sensitivity comes in, based on the culture sensitivity.
Yes.
So I think
same. We also start amoxicillin, clavulanic acid, but problem is 625. If you are starting, you should be giving it 3 times a day. Most of the prescription it is 625 BD. You should not give three times, and ciprofloxacin, as sir said, it is good, but we reserve ciprofloxacin and levofloxacin in view of it is a reserved drug for multi-drug resistant tuberculosis, and most of the periphery people will have a tendency to start linezolid. I request all of you, please don't start linezolid as the first line drug if you see a patient. You are doing harmful things for the society.
Yeah. Thank you. I just want to get this.
Welcome, sir. Thank you.
Any other questions?
Is there any international guidelines for number of sessions yeah, for using hyperbaric oxygen therapy for non-healing ulcer, as you told 22 to 23. Is there a particular guidelines?
So internationally, they are not saying this is the exact number, but they are just mentioning in some article it is better to give minimum 20 sessions for a patient, and it is entirely depends upon the duration of the diabetes and their age and their associated risk factors. There is not such that 10 session or 15 session. They mentioned that because of the meta-analysis of various studies, they say average will be 20 sessions will be ideal. We had also seen somewhere some patients had gone up to 50 sessions also, but some patients had responded at 10 sessions. There is no guidelines which precisely telling a number, ma'am.
Thank you.
Thank you, Ajit. Thank you so much.
Thanks. Welcome.
Let's give them a good round of applause. Thank you, respectful speaker and chairperson, for that comprehensive presentation, combining evidence with your practical experience and expertise in the use of hyperbaric oxygen therapy. I now request you to proceed to the selfie stand for a photograph with the memento.